Thank you very much, Mr. Chairman. Thank you to Senator Alexander and Senator Murray for taking this issue so seriously, convening us here today. I think Senator Alexander's comments, were useful in understanding why Congress really hasn't taken on this issue of comprehensive mental health reform in the past, because it does cut across so many agencies, both latitudinally and longitudinally. It does cut across so many different committees, and I really appreciate the focus on trying to get to a product that can eventually get to the floor. A few of us were at a really interesting bipartisan briefing this morning from the Commonwealth Fund, in which they were talking about the need to integrate our behavioral health systems with our physical health systems. And there were some really interesting facts that they brought out. One of them was that if you study the incidence of diabetes alone as a cost driver, and you study the incidence of mental health diagnoses alone as a cost driver in Medicare, they're actually not that extraordinary by themselves. What makes them extraordinary cost drivers is when they're linked together. When you have a physical health diagnosis and a mental health diagnosis together, all of a sudden you are now in that small percentage of patients that are driving cost. Mr. McRae, is this issue of workforce a question of not having enough providers, or simply not being as coordinated as we should be between the mental health side and the physical health side? Our bill certainly is focused on this question of coordination. Where should our attack be? More providers or better integrated providers?
Thank you, Senator. I think it's actually a combination of the two. I would say that in terms of the primary care piece, we've seen an incredible interest from our primary care providers to increase their capacity to have behavioral health providers on site, because a lot of the primary care providers have shared with us that they sometimes feel uncomfortable in terms of dealing with mental health issues. But by our investments that we've made over the last several years, we've doubled the number of mental health providers that are at our health centers. And by having those providers on site, it's actually helped our screening in terms of what we do. And it's really afforded the primary care system to expand its capacity to do more. So we really see it as we need to build out the primary care capacity to do more screening integrated with behavioral health. But then the second part of your question about whether we have enough providers, I would say we see an incredible demand for mental health providers from our different programs. Right now, we're only able to fund about half of our applications through the National Health Service Corps for mental health providers. Our community health centers, 65% of the demand has been for behavioral health in terms of what they're requesting. So we definitely see the need, both support for coordination, but also providers.
Ms. Inamoto, I want to follow up on this question of HIPAA. That is certainly an aspect of our bill as well. Is this a question of providers not interpreting the existing statute correctly, or do we need clarification of what allows a provider to share information with a family with a family member? I mean, I think Senator Collins has identified a particularly acute problem: the lack of information that goes to parents and caregivers, especially when you're talking about a young adult who may be psychotic, who needs that help and assistance and that coordination. Is this a matter of needing to clarify the standard?
We believe that there are more flexibilities than many physicians and many people understand, and that clarifying the roles and the flexibilities that they have to disclose information to family members when it's in the best interest of the patient would be very helpful to a lot of people. And we're happy to work with our colleagues at OCR and across the department to do that.
Dr. Insel, the time at which you've been at the Institute has roughly corresponded with the period of time in which we've reduced the number of inpatient beds across the country by about 4,000. And mostly that has occurred during the recession and afterwards. That's about a 15% reduction. I appreciate what you're saying in terms of the focus on trying to identify early. But can we sustain this level of continued reduction of inpatient beds over time? Is this something as you leave that worries you, the lack of capacity that we have to provide short-term acute care stays for people that need a period of stabilization?
Oh, absolutely. It's a big issue. There's no room at the inn. There is no place to send patients. Often that's why we see people being boarded in emergency rooms, which is a ridiculous situation that we find ourselves in here. So we need to look at how you expand capacity. It's not the answer to all questions, but that at least needs to be developed. And I should just note that it's the last 13 years, there has been a reduction, but the big reduction came long before that. There's about over 90% reduction in public beds for people with mental illness since the 1970s. So a huge, huge change in what the capacity is to help people when they really need full-time support.
This all changed in the 1960s. We did something great. We took people out of the institutions and we put them in the community, but we did two things wrong. We didn't fund the support in the community, and we set up a community mental health system that was wholly separate and apart from the rest of the healthcare system. And hopefully our discussion will be around those two fixes, making that promise real and bringing those two systems back together.
That would be great. I just want to take another moment to say that we do have a system out there. It's called the criminal justice system, which has become the de facto mental health care system in this country. And I think as you look at legislation, you can't ignore that. You need to really ask on a bipartisan way, is this the country we want to be? Is this the way that we want to treat people with a brain disorder?
Hallelujah. Thank you, Mr. Chairman.